Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform that we use to try and find African solutions for African problems. This month, we're talking radiology with Dr. Dale Creamer. He is the head of the Interventional Radiology Department at Groote Hospital in Cape Town. And in this episode, we talk about access to radiological services and how to distribute resources in an efficient and equitable way that benefits the whole system. We talk about interdepartmental dynamics and how imaging can often be either a rate-limiting or rate-enhancing factor in a patient's journey. We then move on to technological advances in the field, including Dale's speciality itself of interventional radiology, and how investing in these advances might cost a lot of money to set up, but also have the potential of greatly improving clinical outcomes, as well as saving a lot of time and money in the long term. As always, opinions shared represent myself and my guest in a personal capacity and do not represent any institutions that myself nor my guest represent. Also, we acknowledge fully that this discussion might be a bit biased towards the Groote system, as well as the referral hospitals in the Western Cape area, because this is where both myself and Dale work. However, most of the ideas that we discuss and the ways forward in terms of maximizing efficiency are generally applicable to most of South Africa and even the rest of Africa as more resources become available. Welcome to the show, Dale. Could you start by introducing yourself and giving us a brief rundown of your professional career so far?
Hey Dan, thanks for inviting me to come and have a talk with you today. My name's Dale Creamer. I I did my undergrad at UKZN back in the Blue Moon. I can't remember when. I'm joking. It was about 2004, I think I was there. And I finished up in about 2010. I did my internship at RK Khan Hospital in Durban and in community service at Port Shepstone in emergency medicine. I did work a bit as a locum in multiple private emergency medicine departments for about 3 years during my time while I was working as a medical officer in radiology in KwaZulu-Natal. And then I was lucky to get a post in Tygerberg Hospital, the University of Stellenbosch, to train in radiology. And I finished my training and then worked 18 months in private here in Cape Town, in private radiology here in Cape Town, and then went to Canada for 12 months to do an interventional radiology fellowship at the Foothills Medical Center in Calgary. And now I've been working at Groote Hospital for the last 11 months as a vascular interventional radiologist, head of interventional radiology, and working on the development of our own South African interventional radiology training program. So that's kind of what I've been up to.
Awesome. Thank you. We'll get more into the interventional side later and what you guys are doing at Groote and the rest of South Africa. But let's start with your knowledge and experience as a diagnostic radiologist. How can we improve efficiency in diagnostic imaging in South Africa? At the moment, even facilities with CT scanners on site are transferring a lot of patients to tertiary centers or bigger urban centers for CT scans, which costs a lot of time and money, where the limiting factor is the physical presence of a radiologist. Is there a place for fully remote reporting, where all the radiologists sit at tertiary learning centers and report remotely, or even remote radiography, where a radiographer can operate the machine remotely with the doctor putting the patient in the CT scanner, in terms of improving the efficiency that we have at the moment? What are your thoughts on that?
So I think you and I are both well aware that modern medicine is requiring increased imaging in South Africa. I want to change that answer. Sorry. I would probably say modern medicine is now requiring increased imaging, but our South African resources are not matched to accommodate this. And often the transportation of patients to centers which have these available facilities is time consuming and expensive, as you've said. And also it's a waste of ambulance staff, and expertise moving these patients between hospitals. There is inadequate staffing in the peripheral centers in radiology, and sometimes with only one radiologist available during daytime working hours. And that radiologist can't be expected to cover call for the entire month. So, radiographers and sonographers generally in South Africa, we are experiencing a bit of a brain drain. A lot of our radiographers and sonographers being moved to Britain and Australasia. We're struggling to keep up with those specific requirements as a result, because, I mean, even in a major center like Groote Hospital, we're struggling with those staffing requirements. So I can't imagine what's going on in the peripheral centers. So with regards to remote reporting, I mean, it's a possible answer to the problem. The costs of remote reporting are quite high, and reporting radiologists, I'm not sure if you understand how the system would work, but the reporting radiologists in these remote reporting centers are usually not state employees or private public employees, and they're usually private firms that are working in a remote reporting facility, and the costs for these reporting stations are quite high, and eventually become quite excessive in the long term for the peripheral hospitals. Especially because, like I said to you, with the volume of work that we're experiencing with modern medicine, needing more and more imaging. So, a possible solution to do this to this problem is maybe we can centralize peripheral after-hours work to academic centers and employ more registrars with adequate consultant to registrar ratios for work to be checked, and the availability of these consultants for complex queries after hours. So I think there's two variable options here. Is that either we go the way of taking the registrar route with central centers and periphery, managing the peripheral hospitals, or we actually employ these teleradiology or remote reporting firms, which can often be quite expensive. So I think those are the issues here. With regards to remote radiography, I think that's a complex idea. Radiographers train for 4 years and are not just button pushers. And radiation workers are there they study human anatomy, radiation protection, technicalities of expensive machine operation. And I think this can't be reduced to just doctors strapping patients into a machine. Ultimately, there needs to be a greater investment in training radiographers and keeping them in South Africa. And that's something that we need to address.
With regards to the registrars reporting in a central place in a good academic sort of program. So at my hospital at the moment, we've got a radiologist on site for 3 days a week. And then Mondays and Fridays, we can do emergency scans and they will be reported by the radiologist on call at a different hospital. So it's sort of being done at the moment on certain days of the week. And I'm sure all across the country, they've got various adaptations of a similar situation. But after hours, that seems to change to having to move the patient somewhere as opposed to move the reporting somewhere, which is probably just a cost benefit sum that somebody has to do properly.
Look, I think it's definitely something that could be an answer here. But at the moment, if we look at possibly putting together something like this, it would require, I think, a lot more manpower on the ground. And if I give you an example of what's happening at Groote, I mean, Groote, our registrars are quite busy. They're reporting at least 30 to 35 complex scans per evening, and that's just from one center. And then there's one consultant that is covering every night. So when you start involving peripheral hospitals, you're probably going to need another registrar on call to cover a specific amount of peripheral hospitals with another consultant. And those are things that I think in the long term cost saving will be great, and also the capacity for these registrars to train. The more you see, the more you know. It is a possible answer to this particular question. I mean, I'm not really sure I'm not really sure how else to address it. I mean, if we had to say we were living in a country where there was a lot of money available, then obviously you'd have enough staff in your hospital not to just have a radiologist 3 days of the week, and you guys would be able to have the resources that you require. But we're going to have to think a little bit out of the box here. I mean, I haven't seen it being done in the after hours sense in both Tygerberg and Groote hospitals in the Western Cape. It's been done during the daytime working hours where you see these peripheral reporting stations. And then, as you say, after hours, it becomes a problem. So I think it's something that we need to, it'll be something that needs to be discussed, but needs, I think, a bit of a vision going forward with regards to how to cut costs, but also maintain a high standard of service. So those are the questions that I think all of us are trying to answer, and we don't know how to get those answers just yet. But hopefully, with some more discussion, we will.
Yeah, well, hopefully some influential people are listening. Like you touched on, radiologists themselves are a hugely limited resource, and large centers are busy and overburdened. All you have to do is try and phone somebody to realize that very quickly. There is a recent study that I read that came out of Florida that used artificial intelligence to not purely report on scans, but to augment emergency physicians interpreting very specifically non-contrasted CT brain scans to detect intracranial hemorrhages, either traumatic or atraumatic. Um, and that increased the sensitivity to comparable to radiologist levels, and in some cases better. So also going back to our last conversation, non-contrasted CT scans for bleeds are probably the majority of after-hours transfers, as well as emergency remote-reported scans. Do you see any adoption of anything like this, or artificial intelligence or other computer programs to help increase the efficiency where we work?
Yeah, so AI is the latest hot topic, these days, and there's a lot of future prospects for radiology. And I mean, I've been hearing that Groote Hospital is implementing an AI stroke platform soon. We hope to use that to assist our neurointerventional program, because we still have a stroke thrombectomy system going. So I think that will really change things with regards to the speed of reporting, and as well as giving clinicians the opportunities to move. I mean, time is brain, as they say. So it is something that they've had to bring in. However, I think we need to talk about the fact that AI software is expensive, and it requires IT integration. So I'm not sure how that would work in the peripheral setup, And but I do think that there is probably a role for AI. We recently had a presentation at Groote Hospital from a quite well published professor in interventional radiology, but actually now moving more into the AI space. His name is Professor Calvin Hong, and he's a Wits graduate that now works at John Hopkins University. And he was discussing the development. I mean, there's a rapid development of AI at the moment, with multiple programmers, and there's just a lot of development in the space at the moment, mainly because I think that's where they perceive the money to be at. The overwhelming conclusion after his presentation was that as much as AI is growing, and the perception is that it may even replace the radiologist in the long term, medico legally this won't work. There has to be a radiologist who either confirms or denies what the findings of the AI systems are, because ultimately there must be somebody to sue at the end of the day, which is what he said from his own words. So there has to be somebody's name at the end of the end of the reports that can be assigned blame if there is an issue. So I think if we just a final decision made by AI and non-radiologists could have extensive medical legal issues. So I think we have to think about, yes, in our own specific setting, it will definitely help our clinicians make specific decisions quicker, and but we still need to have the resources, radiology resources and expertise to finalize those findings, because at the moment AI isn't perfect.
Yeah, and you say that there has to be somebody to sue or somebody liable for the end of the line decision making. It could still improve quicker decision making, or it could help the emergency medicine to neurosurgery interface, if we think that there's definitely a big bleed here that's possibly intervenable, I'm going to chat to neurosurgery right now, and we can wait for a final radiologist name at the end of the report tomorrow.
Yeah, definitely. I mean, I think the speed of reporting is going to be, much quicker. Obviously, I still think that most of the time when you do these, especially with neurosurgeons and orthopods, etc., who often read their own scans and make their own decisions, um, you know, it does work to a certain extent, and I mean, it has been working for a while. But I think that the fact of the matter is that you still need a radiologist to make these final decisions, because there have been cases where there are specific clinicians that make specific decisions on imaging and miss certain things because maybe they don't have the training to look at the other stuff other than just the bleed, you know. So the job of the radiologist is not just to identify the problem, but to look at the whole scan and to give a clearer indication of the problem. So I think we still run risks of just picking out one problem and fixing that problem, and not actually looking at the bigger picture, which is what the radiologist's job is supposed to be. So yeah.
Just one more thing on that. I'm not a legal person at all, and I've got no expertise in medical legal background, and I'm sure it's a hugely complex question without a simple answer. But if somebody in a low resourced setting is making a decision based on information that they have at the time, and makes a decision in the best interest of their patient, and can be shown retrospectively, even if they made the incorrect decision to do something at the time, without a radiologist report or without a perfect AI answer, that, in my mind, that is still legally quite reasonable. So without somebody taking full accountability for the findings or missed things, if you've seen something that you think is intervenable upon and you've done something in the best interest of the patient, I suppose it matters. It probably differs hugely from case to case, but that would be my logical explanation or way forward. I'm not sure.
No, I think you're definitely onto something there. I mean, we do have this first world, third world clash that we deal with in our healthcare setup, and there are going to be settings where you're going to have to make a decision where the resources that I've described are not available. And I think I'm just talking about it in an idealistic sort of way when I say that it's supposed to have a radiologist available to be the sort of final decision maker with regards to any particular finding or pathology. But I think if you are making, I mean, emergency medicine physicians are doing this every day, and that is making the decisions in the best interests of their patients and using whatever little resources that they have in order to do the best that they can. I think ultimately, you can't be faulted for that. So I'm no medical legal expert myself, but I do think that you know you have to do the best you can with what you've got. So yeah.
All right. And just to follow on with the theme of accountability and risk taking before we move on to interventional radiology. So, in high resource settings and in some private hospitals in South Africa, emergency doctors are made fun of in a light-hearted way by radiologists for
Mm.
requesting scans for everything and outsourcing job to radiology and all sorts of diagnostic dilemmas, or probably like you touched on earlier, from a medical legal perspective, if somebody's a bit short of breath, they need a CTPA all the time, or they get a minor head injury, they need a CT brain to cover yourself medical legally, or just if you want to be very careful. And you would have more experience in private with regard to that too, but from my experience in private, it's quite easy to get scans done. And I don't know if billing plays a role in that decision making. But and in South Africa, in a public setting, I don't think that's the case yet because of the resource constraints on radiologists' time, our time. scan availability, machine availability, and I think that's so.
Mm.
I don't think it's a problem because we have
Mm.
to fight very hard usually for our scans to be done. So while we're on one side of that fence and a lot of people in other places are on the other side, how do we maintain a balance going forward? And how do we not get to the other side? And so I want to sit on the fence, not either side, essentially.
Mm. I was talking to you about earlier about the fact that the demand for imaging has just exponentially risen, and mainly because of it's a term that I don't know, medical legal buffering, so to say. At the end of the day, if you make a mistake nowadays, and in a clinical context, and then they'll ask you, why didn't you image the patient? It's a real difficult situation for a clinician. And a lot of patients are not, a lot of referring departments are not prepared to accept patients without an imaging, some sort of imaging done, so that it clearly defines the pathway that that patient needs to take. So we have these specific situations.
It's objective. It's objective proof.
Yeah. So everybody can look at it, everyone can see, and then they'll
Mm,
say, okay, well, this is the one that I definitely think this is going to the specific
mm,
department or the specific doctor. Within the private radiology space, as you rightly indicated, I mean, the more scans they do, the more money they make. I mean, that's just how it works. But they are also, as a result of the more money that they make, they're adequately resourced. They have enough radiographers, they've
mm,
got enough machines, the machines are well maintained. There's enough systems within the hospital to make sure that these, porters, cleaning staff, security, or whatever. I mean, there's a lot of different factors at play here, but they definitely are,
mm,
well resourced. But in the state sector or in the public sector, you have, you know, which services 60% or more of the population of this country. So you have like these like small silos where private institutions operate, where there's a very small, a small group of patients
mm,
go there, and then in the state sector, you have an exponential amount of scanning, an exponential amount of patients requiring an exponential amount of scanning, with staffing issues. And sometimes, we'll have, I mean, in Groote we've only got two CT scans, two CT scanners, and one radiographer on call
mm,
in the night for those CT scanners. That's just an example, you know. We do have others that are doing, X-ray work, and there's no sonographers on call at night. But those are the things that we're having to deal with in a quaternary center like Groote. So I'm not even sure how that would work in the peripheral centers.
mm,
But there's some studies that have been done that talk about overscanning versus underscanning. So if you look at like a private setting, you'll have, I don't exactly have the percentages, but quite a high volume of the scans will be normal, meaning that they're
mm,
overscanning patients. And then in the state sector, you have more than 80% of those patients being abnormal. Most of 80% of the scans being abnormal, which means we're underscanning patients.
mm,
There's like a healthy threshold that needs to be found. But the
yeah.
result of underscanning is occurred as a result of the fact that resources are limited, and the fact that staffing and etc. is
Mm,
limited. So I was never the kind of I've never been the kind of radiologist that believed in making jokes about clinicians referring cases to us. But like I spoke to you about earlier, at the end of the day, in order to keep an emergency medicine department that's busy running and stopping it from being clogged up, is you need to have imaging.
mm,
You know, so
mm,
you help the process of patients being triaged and moved into specific departments by imaging the patients. So it's all part of the team, right? And I think that radiologists, like I said to you, I can't speak for all radiologists. I speak for myself. That I always had that understanding that I wasn't going to say no if it was going to help the
mm,
process, to help make sure that emergency medicine runs smoothly and that patients are moved to the appropriate areas and taken care of appropriately. That was the main. I mean, at the end of the day, that's why we become doctors, to help patients. So that's the end of the story, right? But as much as you talk about there's this level of ridicule that happens from the radiologist side, I must say that my experience, and whether that be in Canada or in South Africa, that there are emergency physicians that are rude. There are emergency physicians that tell lies, that don't examine their patients. So, like I say to you, you may not be one of those guys. You may be a guy that actually does his work properly, as in, I may be a radiologist that actually wants to report CT scans and wants to help. So you can't really paint everybody with the same brush.
Yeah.
So I think that it really depends. But the solution to that, I think we're probably going to need to sit down and have more interdepartmental meetings and stop working in silos and start thinking, how do we work on things together? Because it's something that I've noticed that there's no communication. There's no let's sit down and talk about cases. Let's have an interdepartmental meeting and let's talk about specific cases from the month. It doesn't even have to be the week, the month that emergency medicine found interesting, and what they thought and what we thought and how we can help, and what were some of the issues that came across as a result from, did they have problems with the porters? Did they have problems with this? What did we have problems with? And how do we work these things out? I mean, those are things that are important. You have to have, if we work within silos like we have been, we're always going to have these issues, but not to say that if we start having interdepartmental meetings that all of a sudden everything's going to be hunky dory. I'm pretty sure that there'll be some issues there as well. But I think that we have to accept that imaging plays a vital role in the movement and triage of patients, right? And we also have to accept
whether that's positive findings or negative findings.
Yes, agreed, absolutely. And especially in our overcrowded setups in emergency medicine departments. I mean, it's overcrowded. Like I said, 60% of the population come into these state hospitals. They're overcrowded and understaffed. We understand the issues that come with working in emergency medicine. So I think definitely we have to work together more to providing the services that are going to be beneficial. I mean, I can tell you a funny story. There was a guy that I'm not going to say which hospital I worked in, but there was this guy who was working in emergency medicine that used to sit on his chair and roll past the patients, and he'd shake their legs. And he'd shake the leg, and then when he shook their legs, he'd say that person needs a CT at the C-spine. And that's what he did, and it was well known that this guy did that, he was just not prepared to examine his patients. He was just like, I think he needs a C-spine. Why don't you just throw it in, why not? So I think, you're always going to have these issues where, you're going to have some people that don't do their work properly, and you're going to have people that bat cases around, So I think the only way to try and work on that is actually to meet as departments, to start talking about our various, in a very calm and organized fashion,
safe,
to discuss things properly, and really come to a point where we can work together as a team. And I believe it's essential.
And I think like so many sort of topics in medicine and so many problems that arise, it's communication that is the issue. And it's communication in a reasonable, usually verbal as opposed to non-verbal space where you can actually talk to each other and understand the difficulties and the intricacies of each case, which don't often present themselves so easily when the patient arrives with a hastily written referral letter, or when it's you speaking on the phone at 3 a.m. and you've got somebody tapping you on the shoulder, and if you've got your other phone ringing next to you on the whatever on either side of the story. So I think it's very important what you're saying, that whatever platform that may help with this, it's communication that will go a long way to not solve but help this problem.
Agreed.
Right. So I'm going to jump ahead. So interventional radiology has a huge scope of practice, which you would be able to clarify. but my understanding is you guys do sort of biopsies, you drain collections, abscesses, you embolize bleeding vessels. But what services do you offer as an interventional radiologist, and what's your bread and butter, and where is it going in South Africa?
Yeah, so I mean, interventional radiology at the moment is there are not many trained interventional radiologists in South Africa, with maybe around 20 that are trained. And then there are some that are diagnostic radiologists that maybe picked up a few skills along the way. And where do I see it growing? I mean, I think that it's very important that, as you've described some of the procedures that we do, I think that, my exposure to what the first world IR setting is like, it was had quite an important role player in the management of patients with minimally invasive methods for hollow and solid visceral embolizations in bleeding. Sometimes in the cases of patients with variceal bleeding that they were not able to sort out fast enough, and you have to do these jugular intrahepatic portosystemic shunts emergency setting setups, but it wasn't really, as the words that I'm using and the procedures that I'm doing are quite, quaternary level, tertiary level stuff, but at the basic level of interventional radiology, you should be able to at least be able to place a percutaneous drain, whether that be CT guided or whether it be ultrasound guided. It saves the patients having a relook and washout laparotomies, and therefore, stopping them having those laparotomies are not always without any
Yeah,
complication.
and the more you do, the more complications there are.
Exactly. So, at the very basic bread and butter of interventional radiology is the ability to access and drain specific collections, especially in patients that are quite septic. So I think if we're looking at it at the very basic of it, that's what I believe we should be providing as all radiologists, not interventional radiologists only. But going forward with interventional radiology, and my sort of vision in South Africa is that I think that it's definitely a growing subspeciality, and the Groote Hospital is quite a blessed hospital in the sense that there was a professor that was there for a while named Prof. Benningfield, Steve Benningfield, that actually built quite a well established referral platform for interventional radiology. And the hospital's quite aware of it. And I walked into it not having to still teach people about what interventional radiology was. And now trying to develop this process where we firstly service our own hospital, but trying to assist hospitals from outside. So Victoria is one of the hospitals that we service. We get a lot of referrals via Vula. We try our best to assist patients, whether it be with bronchial artery embolizations, whether it be abscess drains, whether it be difficult biopsies, whether it would be, I think at the end of the day, interventional radiology is a cost saving measure in surgery, theater time, anesthetics. All those are factors that need to be thought about. And with interventional radiology in our current setup, to do these minimally invasive procedures to help patients, and also in the long term, I think will cost the government less, which is what I'm hoping to use as a motivator to grow the subspeciality within the academic setup, and then see where we take it from there.
Like you said, you're hoping to use it as a motivator to grow the field and use the cost saving as your carrot for people funding these programs. South Africa is obviously a very dichotomous
Mhm.
country in economics, as well as more specifically with medicine, where you've got some areas and some districts and all of that operating at a very third world level and resource space, and then you've got some areas operating at a very first world standard, and that's not necessarily just within the government, that's private, public, etc.
Mhm.
How do you see interventional radiology services being used equitably, and what do you think the best way to try and bridge that gap in terms of location is destiny, or where, for example, you did say that your first goal is to serve your own hospital, but that's completely irrational. You have to start growing your base from somewhere. But how do you see that going forward from a distributive justice point of view?
So I think the Vula platform has been a great addition to our department. I mean, I'm not sure if you guys are. I mean, pretty sure a lot of doctors are using this platform at the moment. I can't speak highly of the pro. I mean, it's just been such a revolutionizing, app. I think that it's really been been great. What it's done for our practice. And, within Gereskir, I've had to do a lot of, without the access of, like I spoke to you about Professor Benningfield being available, but there was also some time in Gereskir Hospital where there was no interventional radiologist available. And it was almost me arriving back at the hospital or arriving at Gereskir after my fellowship and now having to go and sow the seed of interventional radiology, how we can help with oncology patients, how we can help in the trauma setting, how we can help with surgical and hepatobiliary patients, how we can help in general medicine, etc. And I've been trying to grow that sort of understanding with the knowledge that there are registrars that train in these specific areas that go out into other hospitals and will have an understanding of what interventional radiology can do at this specific center. So yes, growing in your base hospital is very important, and that's still an ongoing process with us. But in the peripheral aspect, I must say that has been, unfortunately, our medical team in Gereskir Hospital isn't very happy with us because the influx of patients from peripheral hospitals as a result of the uptake of interventional radiology and the Vula platform has been quite big. So we are taking in a lot of patients. We're trying our best. I think that the platform's been quite helpful in us really discussing various issues with clinicians and assisting the process of moving them into the major centers. Yes, we still have to deal with the ambulances. We still have to deal with, we aren't clinicians. We are radiologists, interventional radiologists. But part of the growth pattern that I'm hoping to put together is there's something now called clinical interventional radiologists. So that basically means that I would hope at one stage that Gereskir Hospital can bless me with a ward, and I can move patients from peripheral hospitals straight into the ward instead of them being admitted by medical physicians or medical emergency, etc. And we manage those patients and send them back appropriately. So I think the initial plan was, yes, we have to work on the base hospital structure and building of interventional radiology. But I think already the uptake from the peripheral hospitals has been quite significant. So at the moment, I think we're servicing as far as George. I'm getting a referral from George on Thursday for a bronchial artery embolization. So those are the kinds of patients that I'm getting in and are being referred via Vula. So I think it will take time. Gereskir Hospital is going to be the first hospital in South Africa that will have 2 fellowship-trained interventional radiologists. So I don't even think there's a private hospital in South Africa that has that. So we're looking at a developing interventional radiology at a very high scale. And yes, we want that to extend to the peripheral hospitals and hopefully help ease the burden of the issues that some of the peripheral hospitals are facing.
Do you see a lot of your registrars and a lot of people that talk to you about radiology in general? Do you see them being very attracted to interventional radiology and registrars wanting to move more into the interventional side from the diagnostic side?
I think yes and no. To be honest with you, while I was a registrar, I wasn't exposed to the level of intervention that we are now doing at Gereskir Hospital. So I think a lot of the registrars are quite amazed that I do, for example, percutaneous gastrostomy tubes, and we're moving into the space of doing pulmonary embolectomies for PEs. Sorry, I don't know why that went. I wanted to say pleural effusions.
You could join those too if you want. We can send you some.
For cut that part. No, I'm joking. Yeah. So so I think there's definitely a new a new car smell going on, and there's a lot of attraction as a result of that. But I do think that there's a lot of radiologists that are, you get radiologists that like to sit down, and you get radiologists that stand up for hours. And unfortunately, I picked the part that you stand for hours and do work. So we do need we need both of those aspects to have a radiology department that thrives. So yes, there is a lot of attraction from the radiologists, the radiology registrars rather, and quite a few of them have indicated that they want to be that I should train them and subspecialize them. It is something we're working on quite actively to get going. I think South Africa had an interventional radiology training program quite a few years ago. I'm talking about maybe 2010, which was in Bloemfontein. And it's subsequently, I'm not sure why it went away, but we haven't been able to train interventional radiologists in South Africa for years. And a lot of us at the moment are having to go to Canada to train. Some of us go to the UK, some of us go to Australia, but a large majority, already, I think in the next year, there'll be 6 Canadian trained interventional radiologists available just in the Western Cape. But obviously, I think most of them are going to go to private. So I think there's definitely something, the change is happening, and there's going to be something happening within the interventional radiology space within the next couple of years. And I do think that in the presentations that I've had with my clinical, colleagues, there's been a lot of interest in interventional radiology. A lot of why do these guys want to help us? But I think the process of interventional radiology is that you need to be that sort of, how do you put it? I think it's been described as the Swiss Army knife of a hospital. Basically, the problem solvers, the guys who are trying to help where no one else can really help, and also to try and do things where patients don't have long-term consequences and suffer as a result. So I think it's been quite, the reception I've gotten from Groote Schuur Hospital, our clinical colleagues, has been great, and it's been growing as a result. So yeah, I think that we're looking at some good things in the next couple of years.
You also mentioned that you're hoping to be blessed with a ward where you can accept patients. Just a question regarding that, because I know you probably are quite frustrated about having to accept someone for a service that you're offering, but they are still housed in somebody else's ward who might be happy or not happy to house them due to whatever space limitations they have or whatever perceived role they might have in looking after them or not looking after them. I find a lot of, even with the diagnostic stuff, a lot of outcomes or a lot of decisions are only made once there's a scan and a report. For example, an MRI. All right. So the MRI scan is done, and then only one can decide if this is a neurosurgical problem or if this is a orthopedic problem or if this is nobody's problem, etc., or a neurology problem, etc. Is how do we break that down? Because a lot of the time, from a peripheral side, we have to discuss and get an accepting doctor. And I know this works slightly differently at different centers, but we face a lot of backlash and time wastage because neurosurgery doesn't want to accept because they think it's an ortho think it's a neurology, etc. And nobody wants to put their stamp on it until they see the MRI. But then you sitting there as the radiologist without a bed to put somebody in. So it's like a whole big catch 22, because it would be a lot easier if we could refer someone to you, put them in your bed, and then they can go to whichever discipline might be able to benefit them after that.
So I think in the diagnostic capacity, it's still, the patients would still need to be. So if we're doing diagnostic imaging, for example, right? So with intervention, it's a procedural based thing. It's like a type of surgery, therefore would require pre-procedure workup and post-procedure management. So basically, what you would do in any sort of surgical ward. But I think within the diagnostic space, we can't, as radiologists, become clinicians and take the patients, especially when you don't know what's going on with them in the first place. And I don't think that radiologists are blessed with the skill set to firstly resuscitate patients. So I think that most radiologists just know how to put up an IV line, which I think is a good thing. The interventional radiologists are a little different, and then we've had to train a bit more. But I mean, most diagnostic radiologists are not going to be in the capacity to take care of patients and sick patients that are there's sort of clinical queries and indecision at the moment with the patient. But in the clinical IR setting, it's definitely something that's been done. It's been working in Europe. It's been happening in the States. We're quite far away from that, but I'm hoping that at some stage we can eventually have a clinical IR setup where patients who come for procedures. So even if it is for uterine artery embolization, for prostate artery embolization, for upper or lower GI bleeding, for bronchial artery embolizations, whatever, from peripheral hospitals, that we admit them into the ward and then that they are seen in the ward by us. And there's no clinical involvement in having to burden our already overburdened clinicians with more patients. These are procedures that we are undertaking. We will accept the consequences for the complications that arise thereof, and they shouldn't be involving our clinical colleagues. So I think that's the long-term vision with regards to the clinical interventional idea. But from the diagnostic component, there's no way we could accept those patients and put them in a ward and wait for a scan. It's just not going to work out. Especially because you don't know what the problem with those patients are, and I don't think radiologists are adequately trained to deal with those patients. So that's my opinion.
One last question. As this is primarily an emergency medicine podcast and we live in a country with a very high trauma burden, in what areas and specific procedures do you see the interface between interventional radiology and emergency medicine going forward with in an acute trauma case or with acute trauma cases?
At the moment, there's just been I walked into Groote Hospital and being the only interventional radiologist there without any real support. I mean, they just have some registrars that are in radiology, which are not subspecialized. They're not even radiologists yet, So it's been difficult to operate at a high level being a standalone person. But I do think that in the next so my colleague, I've got a colleague who's busy training in Montreal at the moment, and he will be returning in the new year, and that's where I said we'll be the first place in South Africa to have 2 guys trained in Canada, and I think that'll be quite great. But I mean, as a result, I haven't been able to really reach out to the emergency side of things, trauma and emergency, because being a one-man show and dealing with trauma and emergency could be disastrous to my health, So it's something that I'm planning to take on as soon as the staffing, as soon as we have enough cover, and we're taking a South African fellow pretty soon. We're working on a South African fellow as well as possibly a fellow from Africa. But once the grand plan is, and maybe we should chat about it at another stage, maybe in a couple of years' time, and see where I've managed to go with this. But I think that we'll have an established platform where we'll be emergency medicine and referring patients with, for example, splenic artery or splenic injuries. I haven't even seen one here. I don't know what's going on. I think people just cut them out here. Yet while I was in Canada, we were doing splenic embos every day. I don't know what's going on there, but I mean, there's a lot of gunshots, stabs, etc. There's a great amount of work that can be done without patients having to go to theatre and with already extremely backlogged systems. We can do that with a patient be consciously sedated, and we can do these little embolizations and they go home. I mean, a lot of these patients that are coming in with stabbed chests and like intercostal artery pseudoaneurysms, I can inject some thrombin into them and then they go home. It's just as simple as that sometimes, So sometimes you can inject thrombin, sometimes I just coil them, but it's a quick, easy way to just sort out certain problems and not have this whole rigmarole of them going for surgery, and then there's the post-operative course that needs to take place, and usually they're in hospital for more than a week, And sometimes they have complications. Sometimes they need to go back for surgery. So those are the types of things that we're thinking about going forward, is that within the emergency medicine and trauma space, to be able to offer a 24-hour service that will help streamline getting patients taken care of and not clogging up the system where possible.
Awesome. Well, yeah, it sounds like you've got a big mountain to climb, but it sounds like it's a mountain that's very worth climbing.
Oh, it's a very big one.
So good luck, and yeah, thanks for sharing your thoughts. And I think this will go maybe not a big way, but some way to bridge that gap between emergency medicine and radiology and improve a bit of communication. And yeah, thanks for joining us. I really appreciate it.
Thanks, Daniel. You take care.
So to summarize a few key points we took away from that conversation, firstly, remote reporting of imaging and scans can be more efficient and is definitely a way forward in the future, but we must also appreciate that it can cost a lot of money. This also applies for artificial intelligence, and while again it might offer a lot of benefit in the future, it is not to be underestimated how expensive this can be, as well as legal implications and who can be held accountable for mistakes and errors when systems do not work perfectly. From a dynamics point of view, we both agree that communication can go a long way into improving the dynamics between emergency medicine and radiology, as well as various other departments who deal with radiology, and it's very much a two-way street when it comes to doing one's job properly and taking pride in one's work. In terms of referring patients directly to a radiologist, in the diagnostic sphere, it can be accepted for now that that's not appropriate, given the fact that a complex patient needs a clinician looking after them. But in the interventional sphere, this is very much a possibility in the near future. And then finally, the field of interventional radiology itself is a huge resource to be tapped and has so many great possibilities for the future in terms of minimizing cost, maximizing efficiency, and really improving patient outcomes in the future. That's all for this month's episode. As always, please like and subscribe on all of your main platforms and share with your friends and colleagues who might find this episode interesting. If you would like to get in touch, please do so. You can send me an email on dan@badem.co.za, and please visit our website www.badem.co.za for more content. Thanks for listening. Bye bye.